everybody, and welcome to Chapter 4. In Chapter 4, we are going to be focusing on anxiety-related disorders. Anxiety, trauma, stress, and other obsessive-compulsive disorders. The first thing I want to do is define what anxiety is. Anxiety is characterized by symptoms of tension in which an individual apprehensively anticipates future danger or misfortune. Responses to anxiety can include feelings, behaviors, and physiological reactions. People who suffer from anxiety often feel intense worry and nervousness. They engage in repetitive behaviors that look to minimize that intense worry and nervousness. They may suffer from chronic nausea, increased heart rate, respiration, and panic attacks, which we will talk about more in just a bit here. It's normal to experience anxiety. We all do to some extent. And in fact, anxiety can actually result in increasing our level of performance. For some people, anxiety and that nervousness, it builds a nervous tension and it helps them to focus, get clarity, and provide just a great, we call these clutch players. For other people, it has the opposite impact. I am not a clutch player. I do not like anxiety. Anxiety does not make me perform well at all, but I know a lot of people who it's actually really helpful for them. But like I said, it's normal to experience anxiety, but too much anxiety can undermine performance. Even if we know that the fear that we are experiencing doesn't make sense or that it's not logical, it doesn't necessarily give us the ability to reduce the anxiety that we're feeling. And anxiety can take over emotionally and physically very, very quickly. Anxiety, like fear, can be an internal warning system to protect us from possible danger, but fear and anxiety are two distinct and separate issues. So just so you can clarify, fear is immediate danger about something that is happening right now, right here. There is something imminently threatening your welfare right here, right now. Whereas anxiety is future-oriented. It's future-oriented worry over things that we can't predict and things that we can't control. When somebody suffers from extreme anxiety, they can also suffer from panic attacks. Panic attacks are abrupt. It's a very abrupt experience of intense fear. People usually feel like when this is happening, they don't know what's happening and they think they're dying because we have increased heart rate, we have increased respiration, sometimes people can't catch their breath, occasionally people will faint or pass out, they'll experience dizziness, chest pains, etc. And if they don't know that what they're experiencing is a panic attack, they often mistake it for a heart attack and they think that they're dying, which makes the whole experience even more scary. Panic attacks are terrifying, but they are not life-threatening. Right? It's certainly an unpleasant thing to experience, but it's not going to kill you. There are two kinds. There are expected panic attacks and unexpected panic attacks. Expected panic attacks only occur in specific situations where there is a trigger that you are aware will cause you anxiety. So for example, if you have a phobia, if you have a phobia of needles, or if you're one of those people who has I am one of these people who has a phobia of driving over very tall bridges, it is a specific issue that will induce anxiety and fear and cause panic in me. But that's the only time it will happen, right? Because it's expected. Versus an unexpected panic attack, where there's absolutely no trigger. It can happen at any time. It can happen without warning, without rhyme or reason. And that's the one that gets really scary for people because there's nothing that you can do to control the environment. So for example, with expected panic attacks, I can avoid tall bridges most of the time, and therefore I don't have to worry about having that anxiety. But if you have unexpected panic attacks, there's nothing that will precipitate the attack. You have no idea when they're coming. Anxiety and panic disorders in general, panic attacks tend to have a genetic component and are familial. So if somebody in your family suffers from one of these, you have a greater likelihood of also developing an anxiety issue or panic attacks. It's not a guarantee, it's a predisposition. However, when we have a predisposition and we increase stress in the environment, oftentimes our predispositions can manifest themselves. I want you to understand the term comorbidity because we're going to be using it a lot throughout this term. Comorbidity is simply the presence of more than one disorder in the same individual, meaning they have more than one diagnosis. There's a high rate of comorbidity in anxiety disorders in general. So for example, there's a high rate of comorbidity between anxiety and depression. There's a high rate of comorbidity between anxiety and eating disorders. So it's the presence of more than one. That when you have one disorder, often they are related to other disorders and you're more likely to have more than one as a result. So the first disorder, the formal diagnosis that we're going to talk about today is generalized anxiety disorder, which we shorten when we're writing just by capital GAD, GAD. This is characterized by an overabundance of worry that cannot be calmed. So there's intense, uncontrollable, unfocused chronic worry. And you can't pinpoint what's causing it. There's no one specific thing in the environment or in your life that you can say, that's what's upsetting me, that's what's giving me anxiety. It's just there. It's there and you don't know why, right? It's unproductive, it produces a lot of stress, and it has a lot of physical symptoms, including constant tension, irritability, and restlessness. People with GAD cannot turn off worry and experience apprehensive worry. So they often worry excessively about something long before it happens, or something that is likely to never happen, right? Some sort of, like unlikely situation where you worry about the death of people that you love constantly in weird circumstances, or that you will get hurt in weird circumstances. This is just an example, but you live in the state of Pennsylvania, but you have excessive worry about quicksand and dying in it, right? It's highly unlikely that that's going to happen in the state of Pennsylvania, but that's something that somebody with general anxiety might have. For example, it's just sort of unrelated, it's unfocused, it's not really an imminent threat, it's unlikely that you'll ever encounter it in your life, but they spend excessive amount of time worrying about things like that, or other unique worries. Physical symptoms of GAD are muscle tension, mental agitation, excessive fatigue, irritability, and difficulty sleeping. Treatment includes drug treatment and psychological treatment in tandem. In specific, psychiatrists tend to use benzodiazepines because they have a calming effect. It is a prescription that has a calming and a stabilizing impact. And when somebody's suffering from extreme anxiety, calm is something they can't achieve on their own. So they use this to stabilize the emotions, calm the individual. But the problem with benzodiazepines is that it comes with side effects. First of all, those side effects impair cognition, it impairs motor skill function. And the big worry is that you can create a tolerance and a dependence. You can become addicted to this sort of prescription. So it has to be used short-term only. It cannot be used long-term. It must be used for short-term. There's been some success using antidepressants to treat generalized anxiety disorder, and psychotherapy focuses on cognition, controlling thoughts and emotional reactions before they spiral out of control. The next disorder that we're going to focus on is panic disorder. Panic disorder is recurrent and unexpected panic attacks that are coupled with concern and anxiety about future panic attacks, which results in noteworthy lifestyle changes to avoid future panic attacks. It becomes a really vicious cycle, right? That you have a panic attack, it's a terrifying experience, and all of a sudden all you can think about or worry about is the next panic attack. And you start rearranging your life and making different decisions so that you can avoid all possible panic attacks, to the point that it becomes debilitating. So some of these alterations can be disabling. So if you have unexpected panic attacks that result in, you're going to experience anxiety worrying about the next unexpected panic attack. Then people start making decisions. So I've known a person who suffers from panic attacks, and one time she suffered from one while she was eating, and after that she would not eat in the house by herself. She was afraid that she would have a panic attack while she's eating, she would choke on the food, there would be no one to help her or give her the Heimlich maneuver, and she would die. This same person also would avoid, and think about how limiting this is, they would avoid highways at all times. She was afraid she would have a panic attack while driving on a highway and crash her car and die. So if you never drive on a highway, think about how your life has to alter to avoid those potential circumstances. Or the fact that you might be home all day by yourself and there's no one else here, and you get hungry, so you have to wait 8 or 9 hours before you can actually feed yourself because you have that much panic. Panic disorder is often accompanied by agoraphobia as a coping mechanism. Agoraphobia is a fear and avoidance of situations in which a person cannot easily escape to get home or to get to a hospital. Agoraphobia is most commonly characterized by people, when it's really severe, they don't leave their house. When it's super severe, making a trip to the mailbox to get the mail is a terrifying experience. The reason being that when you're at home, you can manipulate and control the environment away from the things that can damage you or harm you, or the things that can invoke panic. Agoraphobia can get really out of control for people. There are people who have this and haven't left their home, in some cases, for years, right? The idea being that there's too many things out there that can hurt me. In here, I control what's going on and I can minimize possible threats. But be aware that not all people who have panic disorder develop agoraphobia. It's usually just in very severe cases, okay? And they are distinct issues. They are not one and the same. So how do we cope with panic attacks? There are appropriate and inappropriate ways in which you can cope, okay? Alcohol and drugs to calm oneself, which can be used appropriately, or it can be abused and misused. Avoiding that which triggers panic attacks, which is probably the most common method of dealing with it, especially if they're expected panic attacks. Avoidance of public places that are too far from home or too far from the hospital, because the farther away somebody gets from home or from a hospital, that increases the anxiety and the worry that a panic attack is going to occur and that they have no place to go for safety quickly. The more we have anxiety, the more likely we are to probably have provoke a panic attack, but also it's just a state of terrible discomfort, right? People are often worried about having panic attacks in public and making a public scene. Like I said, when you have a panic attack, you can't control it, you can't speed it up, you can't stop it in the middle, you just have to let it run its course. It's terrifying for the person who's experiencing it, and they don't want people to see them having a freak out in public. So sometimes people will start avoiding public, which is obviously not a good thing. There are some drug treatments that are very successful in controlling panic attacks. And also cognitive behavioral therapy, which is the idea that if we can change our thoughts, we can change our behaviors, all the way down to our panic attacks. Phobias are very common triggers of panic attacks. So I want to talk about different kinds of phobias. Right? And a specific phobia, is an irrational fear of a subject, object, or circumstances that interfere with daily functioning. If you go online and you Google different kinds of phobias, you will find thousands, and there's a specific term for each one. It's kind of crazy how many people have really off-the-wall phobias. I don't know it off the top of my head, but for example, there is a clinical term for people who have a phobia that literally get anxiety about peanut butter getting stuck on the roof of their mouth, that they won't be able to get their mouth open, that they will choke and suffocate. Right, so that's just something fun to do and take a look at. But specific phobias, right, are things that we know trigger specific items that trigger panic, right? There are other kinds of phobias as well that I want to go through. So the first is blood injection injury phobia, which is fairly common. This is excessive fear and avoidance of blood injury or injection. Fear and avoidance of injury is a normal, healthy behavior, right? But you can't go your whole life without exposure to blood, and you certainly can't go your whole life without exposure to injections. And there are oftentimes people who experience it once, it's unpleasant, and they develop a phobia out of the traumatic incident. Eons ago, I shouldn't say eons, I should say maybe 15 years ago, maybe 20, I used to have a blood injection injury phobia. I was getting my wisdom teeth out. I had taken a sedative. I was literally unconscious, and the person administering my IV was not very gentle with me because they thought I was completely out, which I was. I swear they stabbed me in the arm to administer the IV, and it was so painful it brought me back to for about 4 or 5 seconds. And ever since that experience, I was terrified of needles. Now, not anymore, right? I'm a woman, I've had a child, you're gonna go through a lot worse than that, and you gotta get over it, which I did, but for years I would have terrible, terrible anxiety as a result of that incident, that traumatic situation, and it created an injection phobia. I had to get over it, right? And how I got over it is how, we'll talk about that in a little bit, it's called exposure. You cannot go through your life without getting shots, inoculations, tetanus shots, etc. And certainly as a woman, I'm a mother, I've had a child, you go through all sorts of poking and prodding with sharp objects. And exposure made it go away, which we will talk about in a little bit. There's also situational phobia, which is once thought to be a part of panic disorder. It's now viewed as its own distinct phobia. So panic attacks occur when put in phobic situations. So for example, claustrophobia. You know you don't like small enclosed places. The only time a panic attack is going to occur is when you are in a small enclosed place. There's natural environment phobias, which is excessive fear of situations that are found in nature, such as heights or storms or water, etc. I had a friend who suffered from this. she lived in a place with a lot of thunderstorms, and a lightning struck near their house, and it's destroyed a tree when she was a little girl. All the way up well until she was an adult, that experience caused her anxiety and panic. And when there was a thunderstorm, every time she would, turn off all the lights and go in the basement, right? I think she's a little better about it at this point, but she did that well into her 20s, right? Animal phobias is excessive fear of animals or insects. Causes of phobia. So what causes this to happen, right? Talked a little bit about the cause with my needles, which is very common, is to experience a traumatic event that creates a conditioned response. So somebody was really, really rough administering an IV in my arm. It caused pain, which in turn caused panic and fear, and all of a sudden it becomes my conditioned response every time I see a needle. There's also direct experience, which is a situation that causes legitimate alarm, which now becomes a phobia. Experiencing somebody else having a panic attack, panic at a given stimulus, so seeing somebody freak out over bugs or spiders or whatever, you may not have had that problem, but you're watching somebody else do it, and now you feel like there's a reason they're responding this way, and maybe I'm not responding appropriately, and over time it builds a phobia. Hearing about someone else's experiencing panic or experiencing panic at a false alarm, all of these things can cause phobias. How do we get over phobias? Through a concept called exposure, and it's exactly what it sounds like. It is slow and gradual contact to that with which you have a strong fear, right? So if you have a strong fear of heights, what we would do is therapists would start by a step stool. Get on your step stool, and we want you to stand there for 5 solid minutes. And when you experience discomfort, it's fine. We're right here. Just breathe. Look down, understand you're only about 10 inches off the ground. And at the end of that 5 minutes, we see, look, you survived. You were okay. Nothing bad happened. Okay, now let's raise it from 10 inches to 20 inches. And after you get comfortable with that, let's raise it to maybe 5 feet. And after you get comfortable with that, and slowly we increase until your fear subsides because you take small doses and small steps. And that's what exposure therapy is. I want to talk about anxiety disorders that are specific to children. There's 2 that we're going to focus on. The first is separation anxiety, which is something that all children suffer from to some extent when we're small, right? The child is terrified of being separated from the parents. When it becomes a clinical problem is when the separation anxiety gets to the point where they're afraid of not just being apart from their parents, but I'm afraid that if we separate, you're going to die, you're never going to come back, I might be kidnapped, I might get lost, what if I can never find you again? When separation anxiety gets this out of control with children, it gets to the point where they will refuse to leave the home, go to school, and oftentimes will not even go and sleep in a separate room because they're so scared of, if I can't see you, if I'm not here with you, something awful is going to happen. There's also selective mutism, okay? Children who choose to not speak. It's not that they cannot speak. It's not that they have a physical ailment or a disability that's keeping them from speaking, or a cognitive impairment that's not allowing them to learn speech. They can actively speak. But they will only do so in specific environments, and in other specific environments, they will actively choose to never speak. So for example, and this is a result of anxiety, okay? So for example, a child may speak at home but never utter a word in a school setting, even when spoken to by other children or by teachers, right? Both are treated in the same way that anxiety disorders are treated by clinicians for adults. I want to talk about another category now called trauma-related and stressor-related disorders. These are a group of mental disorders characterized by their origin in stressful events. This could be child abuse, this could be being the victim of a violent crime, this could be seeing active duty in war, anything that produces a traumatic experience. The first one is probably pretty well known. We have a good social dialogue on it. It's called post-traumatic stress disorder. It's often abbreviated as PTSD. This is an emotional disorder characterized by distress and feelings of helplessness and extreme fear. Those who suffer from this often relive the previous trauma and develop a numbing response. This is common among people who have seen active war zones, like I said, victims of violent crime, terrorist attacks, even in situations of natural disasters, people can often suffer from PTSD. The treatment focuses on facing the original trauma and experience and the emotions that come with that experience. We want the focus being that you develop a coping mechanism to manage fear and distress, We use exposure therapy here as well, and cognitive behavioral therapy. Next is adjustment disorder. Adjustment disorder is significant impairment or response to stressors that result in negative and emotional behavioral problems. Adjustment disorder is usually pretty short-lived. It only becomes a serious problem if you're experiencing the symptomology beyond 6 months. Obsessive compulsive disorder. We also have a very wide social dialogue about this in our culture. This is characterized by devastating and disabling culmination. It's 2 factors have to be present that results in extreme anxiety. You have repetitive thoughts that cause you distress, right? And they're constant, and you cannot break the thoughts. They will not go away. It's like a mental plague that you cannot get rid of. The thoughts produce excessive anxiety, worry, and fear. So the person starts engaging in repetitive behaviors as a measure of minimizing the anxiety. Often, the repetitive behaviors make no sense relative to the thoughts, right? So you have this extreme distress about something completely unrelated, that if I don't press the button on the remote control 7 times, and if I pause too long between pressing each button, I have to start over again. And if I don't do that, something really bad is going to happen, like I might die. Right? What does pressing a button on a remote control have to do with you dying or not dying? Absolutely nothing, which is what makes this disorder so interesting and so disabling, right? Because certainly that is how they legitimately feel, that if I don't do this, something really bad is going to happen. But logically, it makes no sense, right? It makes no sense. And it becomes debilitating. So if let's say I on the 4th and 5th button presses, I didn't press the 5th button fast enough, I have to start all over again. Right? And I have to do it until I can get that exact rhythm down so that I feel relief. And sometimes people can experience relief, so they will repeat these behaviors 40, 50, 60 times until they get it right. This can be incredibly disabling, right? It keeps people from being able to hold jobs, from being able to hold healthy, functional relationships with other people. Keeps people from leaving their house because they're so busy engaging in repetitive behaviors, right? So there's the repetitive thoughts, and there are the compulsions. And the compulsions are the actions and the repetitive behaviors that are used to suppress the repetitive thoughts and the anxiety that comes with that. Your textbook has 2 awesome tables. One is on page 155, which shows you different types of obsessions and compulsions, how they can range in uniqueness. And page 156 also has an intrusive thoughts table, common intrusive thoughts for people who suffer from this disorder. OCD is strongly affiliated with biological and psychological predispositions. It is largely argued that this could be driven by a gene, but it can also be learned in the environment by mirroring somebody else's behavior. So if you grow up in a house where you have a mother or a father who suffers from obsessive compulsive disorder, you're going to spend a lifetime of witnessing repetitive behaviors, and you might begin to mirror those behaviors and adopt those behaviors. And it might become something that you learn to do over time. I want you to also understand that we tend to throw around the terminology OCD a little too freely and easily in our society. OCD does not mean just that you are a neat and tidy person. There's a really big distinction between being organized, neat, tidy, to the point of perfection, versus having this clinical diagnosis where, like I said, there's often the compulsions make no sense. The obsessions are unrelenting to the point that people cannot function. Treatment of this is very successful with pharmacotherapy using drug treatment. However, because there's a good side and a bad side to that. We see that people's symptomology really declines with drug treatment, but it tends to have to be a lifetime commitment or a long-term commitment, because once you go off drug treatment, relapse is very likely, and it usually happens very quickly. Next, I want to talk about body dysmorphic disorder. This is an overwhelming preoccupation with imagined defects in appearance. There is a very high rate of comorbidity between OCD and body dysmorphic disorder. People with body dysmorphic disorder suffer from persistent intrusive thoughts about their appearance that results in repetitive behaviors. So people who have this problem are constantly checking in the mirrors. There's excessive grooming, excessive plastic surgery. you get one round of plastic surgery to fix whatever the problem is, and either you feel like it didn't fix the problem, so you have to have another round, or maybe it fixed the problem, but now you've noticed some other problem that the individual begins to perseverate on. So when you see somebody who has had 30, 40 plastic surgeries and they now look bizarre as a result, they don't look human and natural anymore, that's very much body dysmorphic disorder, right? That they're constantly looking to fix whatever's there. And if you see the original picture of them before they had the surgeries, you will be like, why would you have done this to yourself? Why would you have changed anything? You looked fine, you looked great even. But they see something else when they look in the mirror. We don't know much about the etiology of body dysmorphic disorder, and there are only two forms of treatment: drug treatment and exposure and response therapy through the conduit of cognitive behavioral therapy. Probably the most famous example of body dysmorphic disorder is Michael Jackson, who had repeated surgeries that changed his appearance to the point that he looked wildly different at the point of death than he ever did before he started having surgeries in his late teens and early 20s. The next is hoarding disorder. This is also something that's come to public consciousness because there's a very popular television show on TLC called Hoarders that goes in, and it's essentially like a mini documentary on the lifestyle of an individual hoarder each week, and how the show goes in to try to administer therapy and get their hoarding under control. These are individuals who cannot relinquish nonsense items. The thought of getting rid of the stuff, whatever the stuff is, results in excessive panic and anxiety. So they keep everything. They never get rid of anything, from garbage to excessive collections of shoes or makeup or figurines or, stationery. I've heard of all kinds of examples, and I've seen all different kinds of hoarding. I've seen a woman who would hoard, and her house was immaculate. It was incredibly clean, and her hoard was incredibly organized. However, she had everything was organized, and they were all in sort of Tupperware containers. It was school supplies, right? She was a former teacher, and she thought, I can always use more pens, I can always use more paper and Post-it notes and paper clips, and now my grandkids can use them, and and she would put them in the Tupperware containers, and she began to stack the Tupperware containers, and so many of them began to overtake her house that you couldn't navigate the house. It wasn't filthy, it wasn't riddled with dirt and rodents or cockroaches, but she literally couldn't live in her house because there was so much of an organized hoard. Versus the alternative, most hoards end up filthy, right? Because there's so much stuff that accumulates, and things begin to decay over time, break down. Oftentimes hoarders are obviously not organized or neat people. So within the hoard, there's rotten food, which draws vermin, it draws bugs, etc., and it becomes a health problem. And a lot of hoarders have their houses condemned, and that's when they have to face their hoarding issue, because they are forced to leave, either clean up the hoard, or you have to leave and your house will be condemned. But doing so causes them extreme panic. They're constantly worried, if I throw this away, something bad is going to happen, because then I'm going to need it down the road and I won't have it, right? I won't have it. So they keep everything, right? And if I keep everything, then I don't have to worry. But this often, like I said, results in physical dangers in the home, right? Obviously fire hazards in a really big way. And it becomes debilitating that you have a home that you can't move in, you can't live in it. Many compulsively shop or use shopping as a way to manage negative emotions. Building that large collection of stuff that they can't part with may be attached with sentimental value. And they often feel like if I were to get rid of my stuff or my items, I am throwing away a part of myself. It's like I'm cutting off my own arm, which all of us would feel distressed at. But that's where the break lies, right? It's stuff, it's not your own arm. But they experience the level of anxiety. This can be treated with cognitive behavioral therapy, but only with moderate success. So far, treating hoarding is a very difficult process, and relapses are very likely. Okay, the next is trichotillomania. This is the compulsive urge to pull out hair from anywhere on the body. Those who suffer from trichotillomania will often chew on the hair follicle after pulling the hair out. This is much more common among females than it is among males, right? And there is a very strong genetic link here, that if you have family members who have suffered from trichotillomania, you are highly predisposed. With increases of stress come increases of hair pulling. right? It becomes very obvious, especially with women. We live in a society where it's okay for men to be bald. It's not okay for women to be bald. But women who suffer from trichotillomania will pull out individual hairs for hours at a time and leave themselves with giant bald spots on their heads. This is followed by fear, it's followed by shame, it's followed by embarrassment, humiliation. I don't want people to know that I do this, I don't want people to see the outcome of this, so they tend to socially isolate and it becomes a bigger problem. When they experience that fear and that stress and that isolation, it provokes more hair pulling. A close cousin to trichotillomania is something called excoriation, which is repetitive and compulsive skin picking that results in tissue damage, which often causes distress, anxiety, and embarrassment. Again, this is largely a female disorder. Trichotillomania and excoriation are often comorbid with obsessive compulsive disorder and body dysmorphic disorder. Both are treated with habit reversal training, which is recognizing urges to engage in these behaviors and begin to replace it with some other behavior. So if you have the urge to pull out your hair, if you have the urge to start peeling skin off your face, you recognize I'm experiencing the stress and the desire to do this, but instead of following up with my typical behavior, what I'm gonna do is engage in some other non-damaging repetitive behavior, like chewing gum, or maybe getting plastic bubble wrap, and I'm going to sit here and I'm gonna repetitively pop the bubbles rather than picking at my face or pulling hair out of my head. That's what habit reversal training is. Okay, that is the end of our chapter on anxiety.